welcome to the deep dive. So you shared your pediatric MSRA revision notes, and we're here to pull out all the crucial bits you need.
Exactly. Think of it as a fast track to getting your head around a key topic.
And today, that topic is aortic stenosis, ASS.
Right, AS. Basically, it's a narrowing, a tightening of the aortic valve.
That's the valve controlling blood leaving the heart's main pump, the left ventricle, right, into the aorta.
Precisely. And when it narrows, the heart, well, it has to work much harder. It's actually a pretty common type of blockage stopping blood getting out of that left ventricle.
Okay. So in this deep dive, we'll cover everything you need for revision. The definition, causes, risks, how it affects the body.
Yeah, what else it might look like, who gets it, how they present.
Diagnosis, management, prognosis, complications, the whole lot.
And we'll throw in some memory aids, maybe a few questions to make it stick.
Perfect. Start with the definition then. What exactly is aortic stenosis?
So, like we said, it's a narrowing, specifically of the aortic valve opening. It physically obstructs blood flow, leaving the left ventricle for the aorta.
And you mentioned causes generally fall into two camps.
Yeah, broadly. You've got the sort of age-related wear and tear, happens over time, and then you've got issues someone's born with, congenital problems with the valve itself.
Okay, so key characteristics we need to remember.
Well, the main thing is that narrowing between the left ventricle and the aorta. It's the most common kind of blockage there. More common in males, actually, about 3 to 1.
Interesting.
And in adults, the usual suspect is calcification, calcium building up, making the valve leaflets stiff.
But in children, it's different.
Yeah, in kids, it's often that the valve's just thicker than normal, or it didn't quite form correctly during development.
Are there specific congenital issues in kids that lead to it?
Definitely. The big one is a bicuspid aortic valve. So instead of 3 leaflets, like normal, these valves only have 2.
How common is that?
Affects about 2% of people, so it's relatively common. And these 2 leaflet valves are just more likely to get narrow or leaky over time.
Okay.
Then there's supravalvular AS, which is above the valve itself. That's rarer, often linked with Williams syndrome.
Great.
And sometimes AS can just be part of a mix of other congenital heart defects.
So picture a normal 3-leaflet valve, nice and flexible, versus this tight, rigid AS valve.
Exactly. Oh, and just quickly on adults, before you get the full-blown calcified stenosis, you often see something called aortic sclerosis first. That's just stiffening, kind of a precursor.
Got it. Sclerosis, then stenosis. Let's dig into the etiology, the specific causes.
Right. So number 1, as we said, is that age-related calcification. Degenerative stenosis. It just wears out over time.
Okay.
Number 2, those congenital malformations. Bicuspid aortic valve is the main one there. Because they're structured differently, they often run into trouble, narrowing or leaking much earlier than a normal valve.
Makes sense.
And then less commonly these days, you have things like rheumatic fever.
Ah, the post-rep third thing.
Yeah, that inflammatory condition. It can damage heart valves, including the aortic valve.
Yeah.
Used to be a bigger cause, but with antibiotics, it's much rarer now in places like the UK.
Okay. Any other inflammatory causes?
Occasionally, yeah. Other things can affect the valve, but they're less common than degeneration or congenital issues.
So mostly age and being born with it. Got it. What about risk factors then? What makes someone more likely to develop AS?
Okay, several things. Age is a big one, obviously. The degenerative type just takes time.
Right.
Having any kind of congenital heart disease history, especially that bicuspid valve, puts you at higher risk.
Family history plays a role too.
It can, yeah. Suggests maybe a genetic link sometimes. And interestingly, things like high blood pressure hypertension.
How does that link?
Well, it likely increases the stress on the valve over time, potentially speeding up the wear and tear. And then conditions linked to inflammation or calcium buildup. So a history of rheumatic fever, even if it's rare now, is a risk factor, and chronic kidney disease too.
Right, the body's handling of calcium can be affected there.
Exactly.
And you mentioned some specific syndromes earlier. Can we recap those with that memory aid?
Yeah, good idea. Williams syndrome is a key one, associated with supravalvular AS, probably due to issues with elastin.
Okay.
Also associations with coarctation of the aorta, a narrowing of the aorta itself, and Turner syndrome.
And the memory tip was?
Think ages and associations. So age, anomalies, congenital, ancestry, family history, arterial pressure, hypertension, and ailments, inflammatory calcium ones.
Ages and associations. Nice.
And for the specific syndromes, remember what? Williams, aortic coarctation, Turner's.
What's perfect?
And just really hammer home that bicuspid valve. increases risk of both stenosis, narrowing, and regurgitation leaking.
Okay, great mnemonics. Let's shift to pathophysiology.
Yeah.
How does this narrowing actually mess with the heart?
Okay, so the narrowed valve means the opening, the orifice area is smaller. Simple mechanics, really.
It makes it harder for the left ventricle to push blood out.
Exactly. The resistance goes way up. The ventricle has to work much, much harder, generate higher pressure to force blood through that tight opening.
And how does the heart respond to that extra work?
It adapts initially. The muscle wall of the left ventricle gets thicker. We call that left ventricular hypertrophy, or LVH.
Like lifting weights makes your biceps bigger.
Sort of, yeah. It's a compensatory thing, trying to maintain the pumping force.
But it doesn't last.
No. Over time, if the stenosis is bad and isn't fixed, that thickened muscle can become stiff. It doesn't relax properly, which affects filling.
So diastolic dysfunction first.
Often, yeah. And eventually, the pumping itself, the systolic function, can become impaired. And that's when you start heading towards heart failure. The heart just can't meet the body's demands anymore.
So adaptation, then stiffness, then failure. Makes
Yeah.
sense. Okay, if someone comes in with symptoms suggesting AS, what else could it be? The differential diagnosis.
Right, really important. Because the main sign, the murmur, can be caused by other things. First, there's aortic sclerosis.
The stiffening we mentioned earlier.
Yeah, the valve is thick and stiff. Maybe some calcium, but not significantly narrowed yet. Can still cause a murmur, though.
Okay. What else?
Aortic regurgitation, the leaky valve. Usually a different kind of murmur, diastolic, but sometimes there are systolic flow changes, too.
Infection.
Yep. Subacute bacterial endocarditis, infection on the valve, can cause a new murmur, fever, feeling unwell.
Yeah.
Aortic root dilatation, where the aorta itself widens near the valve, can sometimes distort the valve. Then you've got flow murmurs.
Innocent murmurs.
Exactly. Very common, especially in kids. Caused by fast blood flow across normal valves. Think fever, anemia, rapid growth spurts.
In an adult.
Similar things, maybe hyperthyroidism or even severe aortic regurgitation, can cause increased flow, leading to a systolic murmur. Plus, you need to consider murmurs from other valves, like the pulmonary valve, or from holes like an atrial septal defect.
That's a lot to think about. Anything else specific to pediatrics here?
Well, distinguishing innocent flow murmurs in kids and newborns from mild AS can be tricky. You really need to listen carefully to the murmur's characteristics, timing, location, sound.
Right.
And just remember the bigger picture of aortic valve disease. AS is one type, but other issues, like valves that are mainly leaky from birth, are also in the differential. Suspicion might arise around age 2 sometime.
And age is key, especially with those innocent murmurs in kids.
Absolutely. Always consider the age.
Okay, let's talk epidemiology. How common is AS, especially in the UK?
It's definitely a significant issue, particularly as the population ages. More common in Europe and North America.
And prevalence increases with age?
Dramatically. It's really common in older adults. Something like nearly 1 in 10 people over 80 might have it to some degree.
Wow.
Much less common in younger folks. And that rheumatic fever cause is pretty rare now in the UK.
So overall in the UK?
Estimates suggest around 3% of people age 75 plus have AS. And looking at congenital heart defects, AS makes up about 5% of those cases.
So definitely something you'll see, particularly in elderly care. Right, clinical features. How does AS actually present? Symptoms, signs.
It varies a lot, depends on severity and age, but there's a classic symptom triad. Use the Mnemonic SAD,
SOD.
syncope, fainting, angina, chest pain, and dyspnea, shortness of breath.
Okay, syncope, angina, dyspnea.
So patients might complain of chest pain, often worse with activity, shortness of breath, again, typically on exertion first. General fatigue is common too.
Lightheadedness.
Palpitations.
Yes, those two. And actual fainting spells, the syncope. In really bad cases, you get signs of heart failure, swollen legs, fluid buildup.
Can heart failure be the first sign?
Sometimes, yeah. Sudden unexplained heart failure should definitely make you think about severe AS. And a subtle sign in severe AS, the second heart sound, the aortic part, can get really soft or even disappear.
Okay. And what about physical signs on examination?
Several key things. The pulse might feel weak and slow rising. That's called pulsus parvus atardicis.
Slow and small pulse. Right. You might find a narrow pulse pressure, not much difference between the top and bottom blood pressure numbers.
Okay.
Feeling the chest, you might detect a vibration over the aortic area, a thrill. That's the turbulent blood flow. And signs of that left ventricular hypertrophy we talked about, maybe a forceful heartbeat you can feel.
And the murmur.
Ah, the murmur. That's the classic sign. Usually that second heart sound, A2, is soft. The murmur itself is harsh, happens during systole when the heart pumps.
An ejection systolic murmur.
Exactly. And it typically radiates up into the neck towards the carotid arteries. It gets louder, then quieter, crescendo decrescendo.
Always the loudest.
Usually the base of the heart, upper right side of the sternum. But a key point. If someone's in severe heart failure, the flow might be low, and the murmur could actually sound quieter. Don't be fooled by that.
Good point. Any other sounds?
Sometimes, especially with a bicuspid valve, you might hear an ejection click just before the murmur starts. And in severe AS with bad LVH, you might hear an extra heart sound, an S4, just before the main lub.
Okay, quite a detailed picture. How does presentation differ in kids, going back to our pediatric focus?
Right, crucial difference. Mild or moderate AS in kids, they might have 0 symptoms, the murmurs found on a routine check.
But critical AS in newborns?
That's an emergency. They can be blue, cyanotic, cold hands and feet, weak pulses, maybe an extra heart sound, a gallop.
And slightly older infants?
They might show signs of heart failure, difficulty feeding, breathing fast, tachypnoea, maybe an enlarged liver.
And older children, adolescents.
With more significant AS, they might get tired easily, have chest pain sometimes, or collapse, especially during exercise. You'll hear the ejection systolic murmur, and if they also have a leaky valve regurgitation, you might hear a diastolic murmur too.
So a huge range from asymptomatic to critically ill. How do we pin down the diagnosis and figure out how bad it is? Investigations.
Echocardiography, the echo, that's the absolute key test.
Ultrasound of the heart.
Yep. It lets us see the valve, how thick it is, how well it opens. And crucially, we use Doppler to measure blood flow speed across the valve. That lets us calculate the pressure gradient, how much harder the ventricle is pushing. That tells us the severity.
What about ECG?
ECG can be useful. It might show signs of that left ventricular hypertrophy or strain.
Chest X-ray.
Can sometimes show an enlarged heart or calcium on the valve, especially in older people. Not always that helpful for diagnosis itself, though.
Exercise testing.
Yeah, that can be really useful, particularly in adults who say they don't have symptoms. See if symptoms or blood pressure issues pop up during exercise. Assesses their functional capacity, too.
Any more advanced imaging?
Sometimes. CT scans or cardiac MRI can give very detailed pictures of the valve and aorta, but they're not usually the first-line tests for diagnosis.
Look us.
Natriuretic peptides, like BNP. Levels can sometimes give clues about heart strain and prognosis, but they don't diagnose AS itself.
And cardiac catheterization. Invasive tests.
Yeah. Less common now for just diagnosis because echo is so good. But might be needed if echo results are unclear, or to directly measure pressures, or, importantly, to check the coronary arteries for blockages, especially before surgery in older patients.
Okay, echo is king. You mentioned severity grading based on echo gradients. Can you remind us of the numbers?
Sure. It's based on the pressure difference across the valve. Mild AS is usually a mean gradient under 25 mmHg, peak under 40.
Moderate.
Mean gradient 25 to 40 mmHg, peak 40 to 70.
And severe.
Mean gradient over 40 mmHg, peak over 70 mmHg. Those are the rough categories we use.
Useful numbers to keep in mind.
Okay.
When should we refer someone with AS to cardiology?
Okay, clear guidelines here. Adults with moderate or severe AS definitely need referral.
Even if asymptomatic?
Yes. And all adults with a bicuspid aortic valve, regardless of how bad the stenosis or leak is currently, need cardiology follow-up because of the long-term risks.
What about pregnancy?
Any pregnant woman with any known valve disease, including AS, needs specialist cardiology IMPIN.
And for kids?
Any child with suspected or confirmed AS needs to see a pediatric cardiologist. Simple as that.
Right. Specialist territory. Let's talk management. What are the goals and strategies?
The main goal is to relieve that obstruction, stop the heart failing, and ideally avoid or delay needing a valve replacement if possible, though that's often the ultimate fix.
Is balloon valvotomy an option? Stretching the valve open?
It can be, especially in kids with congenital AS. It might be done if the pressure gradient is really high, say over 60 mmAh. It can buy time. In adults with calcified valves, it's less effective long-term, more of a temporary bridge or palliative thing sometimes.
And medications. Can any drugs fix the valve?
No, unfortunately not. There's no medicine that reverses or improves the stenosis itself. Medical treatment is all about managing other cardiovascular risks, blood pressure, cholesterol, diabetes, and treating heart failure symptoms if they develop.
What about statins? Do they help?
Good question. They're great for cholesterol and general heart health, but studies have shown they don't actually stop aortic stenosis from getting worse.
Okay, so meds are supportive, not curative.
Exactly. And maybe meds to control heart rhythm if arrhythmias become a problem.
How does management change based on symptoms?
Big difference. If someone has severe AS and is getting symptoms that SAD triad, then aortic valve replacement is usually strongly recommended and fairly urgently.
Unless they're too unwell for other reasons.
Right, unless other major health problems mean they wouldn't benefit or survive the procedure long. But generally, symptoms plus severe AS intervention.
What about severe AS without symptoms?
That's trickier. Intervention valve replacement might be considered if the echo shows the heart muscle is starting to weaken, the ejection fraction is dropping.
Or if the exercise test causes problems?
Yes, if they develop symptoms or worrying signs during exercise testing, it's a careful balance of risks and benefits in asymptomatic severe AS, weighing up the risk of waiting versus the risk of the procedure.
Okay. You mentioned valve replacement. What are the main types of intervention?
Two main players now: surgical aortic valve replacement, SAVR, and transcatheter aortic valve implantation, TAVI.
SAVR is traditional open heart surgery.
Yes, cut open the chest, take out the old valve, sew in a new one, either mechanical or biological tissue. There are minimally invasive surgical options too now.
And TVI.
That's the less invasive one. A new valve is put on a catheter, usually fed up from an artery in the leg, sometimes the chest, and deployed inside the old diseased valve, kind of like a stent for the valve.
Who gets TVI versus SAVR?
Historically, TVI was for older, sicker patients who were too high risk for open surgery, but now it's being used more and more, even in lower risk patients. The choice depends on age, health, heart anatomy, patient preference. Lots of factors. Each has pros and cons.
Any other interventions?
Well, that balloon valvuloplasty we mentioned, mostly palliative or bridge in adults, more therapeutic sometimes in kids. And the Ross procedure, using the patient's own pulmonary valve, that's complex, sometimes done in younger adults, but it's a bit controversial.
Right. What if someone has AS but doesn't need intervention yet? How are they monitored?
Regular follow-up is key. Adults with mild or moderate AS who feel fine usually get checkups and echoes every few years, maybe every 3-5 years for mild.
And asymptomatic severe AS?
Much closer follow-up. Checkups and echoes maybe every 6 to 12 months to catch any early signs of trouble worsening stenosis, symptoms starting, or the heart function dipping.
Okay. Can you touch on the NICE guidelines briefly? What's the UK stance?
Sure. NICE generally recommends intervention for symptomatic severe AS. They advise considering intervention for asymptomatic severe AS based on those risk factors like poor LV function or bad exercise test results.
TAVI versus SAVR?
They recommend TAVI for patients at high surgical risk. For lower or intermediate risk patients, surgery, SAVR, is often considered the first choice, though TAVI's role is expanding. Current NICE guidance reflects cost-effectiveness data at the time, suggesting TAVI wasn't cost-effective for lower-risk groups then, but this is evolving fast.
What about failing replacement valves?
Yes, they mentioned that too. If a biological prosthetic valve fails and becomes severely narrowed, causing symptoms, they suggest considering either another surgery or a transcatheter valve procedure.
Okay, good overview. What about the future for these patients? What's the prognosis?
It really varies hugely. Depends on severity, symptoms, overall health, other conditions.
Any difference between men and women?
Some studies suggest women might actually have worse outcomes, maybe delays in diagnosis or treatment. It's not entirely clear why.
And sudden death risk?
It's a known risk, especially once symptoms develop, but actually quite rare in people with severe AS who genuinely have no symptoms.
What are the chances of staying symptom-free if you have severe AS?
It varies a lot. Maybe only 20% stay symptom-free over 2 years in some groups, maybe over 50% in others. We look at clinical signs, echo findings, exercise tests, blood markers like BMP to try and predict who's likely to develop symptoms sooner.
But once symptoms start?
The outlook without treatment is generally poor. 5-year survival rates can be as low as 15–50% if severe symptomatic AS isn't treated.
But valve replacement helps significantly.
Massively. Improves symptoms, quality of life, and survival. In older patients getting AVR, their long-term survival can be pretty similar to others their age without AS.
And younger patients.
They also benefit hugely, but their survival might still be a little lower over the very long term compared to healthy peers. There are factors that predict worse long-term outcomes after AVR too.
Like what?
Older age, having other medical problems, worse symptoms before surgery, a weaker heart muscle, arrhythmias like atrial fibrillation, or having untreated coronary artery disease alongside the AS.
Really highlights getting treatment sorted once it's needed. Finally, what are the potential complications if AS is left untreated?
Several serious ones. Heart failure is the big one. The heart muscle just gives out from the strain.
Arrhythmias.
Yes, the structural changes can mess with the heart's electrical system, irregular heartbeats, dizziness.
Infection risk.
Definitely. Infective endocarditis. That damaged valve is like a target for bacteria. Needs long courses of antibiotics.
Anything else?
Embolism. Bits of calcium or clot can break off the valve, travel in the bloodstream, and cause damage elsewhere, like a stroke if it goes to the brain.
And the worst case?
Sudden cardiac death. Rare, especially if asymptomatic, but it can happen, particularly with severe disease.
Okay, that wraps up our deep dive into aortic stenosis. It's clear it's a major condition. Key takeaways for revision. Remember the definition. The main causes are age and congenital bicuspid valves.
Remember, ages and associations for risks, SAID for symptoms.
And echo is key for diagnosis and severity. Management depends hugely on symptoms and severity, often leading to valve replacement.
And don't forget those complications, heart failure, endocarditis, stroke risk. Highlights why management is so important. It's definitely high yield for MSRA.
Absolutely. Okay, quick revision question for you listening. A young child presents with poor feeding, tachypnoea, and an ejection systolic murmur. Which congenital heart defect is high on your differential?
Hopefully aortic stenosis is right up there on your list.
Definitely review your notes and maybe listen back to this to cement those ideas.
And a final thought to ponder. With TVI becoming so much more common, how do you think the management of congenital AS in kids might change over the next decade? Something to watch.
And for more revision help, don't forget pastthemsra.com.
And freemsra.com.
Great resources there.
Thanks so much for joining us on this deep dive into aortic stenosis. We hope it's helped clear things up for your MSRA prep. Until next time.